Good evening, everyone, and welcome to the CamAPS FX webinar series. Please make sure that your cameras are off and your mics are on mute, please, for the duration of the webinar. Please ask your questions via chat. We will take them at the end. And do be aware that we are recording this webinar and it will be uploaded on the CamAPS FX training site, so you can watch it later. So the people on the panel today are Charlotte and Sarah. We have heard from them before, and I will be moderating as usual. We are very lucky to have Annika and Fiona with us. They will be sharing their stories later on, and they will be here to answer questions. So I am looking forward to this webinar around living with long-standing type 1 diabetes and how CamAPS can maybe help support issues that develop. I'm going to hand over to Sarah to take us through the webinar. Thank you, Sarah.
Thanks, Candice. So just as a brief outline, we're going to whiz through once again how the system works for those of you who maybe haven't seen any of the other sessions. We're going to talk about the types of diabetes-related complications and comorbidities that people with type 1 diabetes, long-standing type 1 diabetes, can experience, and then focus on the ways that the system can be adjusted to suit some different conditions. So we're going to focus on renal disease, retinopathy, gastroparesis, steroid therapy, touch on COVID-19, and also just touch on using the system with older adults with type 1, and also, because we've had lots of questions, the use of the system during surgery and sort of minor procedures as well. Thanks, Candice. So just to whiz through, if you're not familiar with the system, then if we direct you to either webinar 1 or 2, that can give you a much fuller overview. But just to whiz through, this is the CamAPS FX hybrid closed loop system. So it's an Android smartphone, hosts the app, and it links with the Dana insulin pump, either a Dana RS or now with the Dana I insulin pumps, and also with the Dexcom G6 CGM. We'll link with Dexcom G7 when that comes out, and the system sends data automatically to the DiaSend cloud. And it works by adjusting insulin delivery by turning off the pump's preset basal and instead giving a really small extended bolus every 10 to 12 minutes based on the sensor glucose levels. And when the system's running in auto mode, you see no delivery flashing on the screen like you can see in that photo there, because what that means is no standard basal insulin delivery. It's switched it off and it gives a small extended bolus, like I said, every 8 to 12 minutes. If there was an issue with the pump would be beeping or buzzing and flashing occlusion, low reservoir, low battery, those sorts of other things. The reason it's hybrid closed loop is because it still requires insulin boluses for carbohydrate. We currently just haven't got fast enough acting insulin yet to allow it to be a completely closed loop, fully closed loop. Thanks, Candice. And just in terms of which settings make a difference, so to start the system, all it requires is the body weight and total daily dose. And then other than reading the carb ratio direct from the pump for the carbohydrate that's entered in for meal boluses, the rest of the settings are calculated by the algorithm itself. So it learns insulin sensitivity or correction factor and active insulin time as it goes on, and optimizes learning over sort of 2 to 3 weeks. And it adjusts based on obviously the real-time CGM readings. Thanks. And so the settings that make a difference to optimize the system is literally just the insulin to carbohydrate ratios, which you would adjust on the pump and the system reads them from the pump. And then you can also adjust the glucose target. So it defaults to a target of 5.8 millimoles per litre, but it can be adjusted anywhere between 4.4 and 11, and that's been extremely useful, especially when we'll hear from Annika shortly. That was the settings of those kind of adjustments using much higher targets to start off with made a huge difference for her. And the settings that don't make any difference in closed loop operation are the active insulin time, the sensitivity, and those pre-programmed basal rates, but they all need to be set, because if the system comes out of auto mode, then the pump will revert back to those normal settings. Thanks, Candice. So I'm going to hand over to Charlotte to talk about different type 1 diabetes related complications and comorbidities, and how the system can be adjusted we'll go through how the system can be adjusted for those different conditions.
Thanks, Sarah. So I know it can always be quite a difficult topic to think about in terms of complications of type 1 diabetes. And really what we're talking about here are in particular those sort of areas that are listed here. And what we're trying really to do is we don't have really good evidence of closed loop systems in these particular cases. And that's because often people with these conditions are often excluded from clinical trials. And what we want to do in this webinar is say, okay, actually, people can be using closed loop with various degrees of eye problems and kidney impairment, but how the system can be adjusted to suit the needs of that person. So what we're talking about is things like cardiovascular disease, so heart attack and stroke, kidney impairment, which can be anything from some protein leak in the urine to the need for dialysis, retinopathy and all the degrees of retinopathy, neuropathy or damage to the nerves, and foot disease. And many people will not have any of these complications, and some people might have one more than other, but it's really just to sort of address how to adjust the closed loop system to suit these. Thanks, Candice. So first we're going to touch a little bit on kidney impairment. So what are the challenges with managing type 1 diabetes if you've got some degree of kidney impairment? So what tends to happen is the kidneys get rid of insulin. So what you find is if the kidneys are not working so well, that actually the insulin hangs around the body longer. And this combined with the fact that kidneys produce some glucose of their own, therefore, if there's kidney impairment, they produce less glucose. So these two things combined mean that people who have some kidney impairment often have an increased risk of hypoglycaemia. And that's just worth bearing in mind. So some of the tips for using the closed loop system, if you've got any kidney impairment, is firstly, we know that closed loop can help improve glucose control compared to other diabetes therapies. So it's a positive thing. And it might be worth thinking about using a higher glucose target, because we really want to be thinking about reducing the risk of hypoglycemia, which can be caused by the things I've mentioned previously. So think about starting particularly with a higher glucose target until you see how things go. And what we do know, we have done a study with a different closed loop system to this, but very similar in terms of the component parts that Sarah alluded to. And what we managed to show is that actually the excursions that happen in terms of insulin and glucose that happen with dialysis can be managed by the closed loop system, but perhaps thinking about using something like ease off, which makes the algorithm a little bit less aggressive or deliver less insulin if you are having dialysis. So what about retinopathy? So we know that if people have a rapid improvement in their glucose levels, then this can, in the short term, increase the risk of developing retinopathy. And we see this most commonly in pregnancy. So often women are rapidly achieving tight glycemic control during their pregnancy. And so we keep a much closer eye on retinopathy. What we also know is in the long term, the improved glucose control has more beneficial effects on any retinal disease or effect on the eyes. So it's just a case of monitoring more closely, and it shouldn't be avoiding going on to a system that will improve glucose control, because in the long term there are definitely benefits. But what we might suggest is that actually if you're starting closed loop and your pre-closed loop HbA1c was a little bit higher, so over 10% or 86 millimoles per mole, or you had a particularly low time in target glucose range, then you might think about using a higher glucose target initially with the closed loop system. So the default is 5.8, but you might think about starting this at sort of 8.5, 9, and gradually reducing this over the following weeks to months. And it's really important that you alert your healthcare professional to any changes in vision, particularly if you think that actually you've been starting with suboptimal glycemic control and things are rapidly improving. So just to be a bit mindful of that. If we think about people with visual impairment, often people find that with certain degrees of visual impairment, it's possible to use a smartphone app. You can often increase the size of the font on the app, or use visual sort of support with magnifying glasses and things to be able to see the CGM data, and also because you're bolusing through the app here, it makes it a little bit easier as well. So we do have a few people who've got some degrees of visual impairment who are able to use the system. Set changes, however, can be a bit more challenging as they require you to be able to see the pump screen, which on the Dana RS can be quite small and difficult to see. We've managed to sort of have workarounds for that for certain people, but it's just worth bearing in mind. The app is probably slightly easier to manage, and if people have sort of a care or support worker, then perhaps thinking about doing set changes with support might be worthwhile. What about people who have impaired awareness of hypoglycemia? Well, we know as we get older, our awareness symptoms of hypoglycemia diminish, as well as changing potentially. One thing we do know about all closed loop systems is that they can reduce the time spent in hypoglycemia, and that's including in people who have a high burden of hypoglycemia at baseline. And you can see in this graph here, this was a study which compared pump and sensor with closed loop. And so the blue bars are those with pump and sensor, and the red bars are those with closed loop. And over the first 4 weeks of a period of closed loop, you can see that there was much less time spent in hypoglycemia with the closed loop system than with pump and sensor. So there's pretty good evidence that closed loop systems can help with hypoglycemia. And there's recently been a really exciting study which has been done with a different closed loop system, which looked at people who have a really high burden of hypoglycemia or hypo unawareness at baseline, and their data is about to be produced. And what we don't know yet is to whether closed loop systems are able to restore hypoglycemia symptoms, and that really would be a sort of a really impactful benefit of closed loop. But at the moment we don't yet have that data. But I think this isn't something that needs to be avoided by people with impaired awareness of hypoglycemia, but should hopefully benefit.
Thanks. So I think I'm going to take over at this point. So just to now consider gastroparesis. So gastroparesis is delayed gastric emptying and delayed absorption, therefore, of any carbohydrate that's been ingested. And it normally occurs because of damage that's been done to the nerve endings that would normally cause the stomach to empty in the way that you would normally expect it to. And the problem with that, particularly when you're trying to match insulin with carbohydrate, is that you get these unpredictable glucose rises after meals, or sometimes if there's vomiting, you can have drops in glucose if you've already had the insulin for what you've eaten. So you get this erratic glucose profile with really high glucose variability. And difficulty because of what's going on in pre-meal bolusing, because often people will say, I just wouldn't dare to have my insulin before I ate because they're worried about the hypos. And overall, can be pretty miserable for people, a real significant impact on quality of life. So there is a really small amount of evidence suggesting that hybrid closed loop systems might be beneficial for people with gastroparesis. It's just something that's sort of being looked into more now, but there's a couple of studies. The data that you can see at the top is from a handful of cases in our service in Cambridge, and then there was an additional small study looking at just 5 patients with type 1 diabetes and gastroparesis, and looking at the increase in time in range using closed loop systems. So what the data so far has shown is that there's increased time in the target glucose range using hybrid closed loop systems, without, importantly, having any increase in hypoglycemia. But it's yet unclear if closed loop systems can improve gastroparesis. I think often pre-closed loop, if we had people with gastroparesis, they would see the gastro consultants who would say, you know, the only way to improve your symptoms is to improve your glycemic control. But then it's kind of chicken and egg, catch-22. It's really difficult to improve your glycemic control when you've got those symptoms of gastroparesis. So what we're hoping that, you know, if more people get access to this kind of technology, then we can start to see if it makes a difference to improve the symptoms. And again, Annika can share her story with us in a couple of minutes. So in terms of the particular features the CamAPS FX system has that are useful for gastroparesis is it's licensed for use with ultra rapid acting insulins, so for Fiasp and Lumiev. So that means that you know, ideally in this situation you want insulins that are quicker on, quicker off, and it can be used with those. It also has a slowly absorbed meal function, which we'll look at in just a minute, and it has you can adjust the pre-meal bolus, give a different percentage up front, and then use the boost or the slowly absorbed meal for the remainder to try and kind of match the delayed glucose absorption, which can work quite nicely for some people. The other thing that's really, really useful, especially if people are using the system where they have had slightly higher A1Cs, again, as Charlotte was saying, anything sort of above 10, consider starting with a higher glucose target. So as I said before, you can start at anywhere from 11 millimoles per litre and then drop it down gradually as controlling improves. You can also raise the low glucose alert, so you can have the threshold slightly higher and respond to any sort of hypos, or glucose is heading towards hypo territory earlier, because obviously it can take slightly longer for the oral glucose treatment to be absorbed. So just to recap on managing slowly absorbed meals, we kind of have a sort of stepwise approach for this, really. The first thing that we'd normally suggest with people, you know, not even talking about gastroparesis necessarily, but maybe just meals that are higher protein, higher fat, and you know, we're going to be sort of lower glycemic index carbohydrate, is giving the pre-meal bolus and just first of all allowing the algorithm to deal with the carbohydrate as it comes through. And for many, just putting the full bolus in and delivering that bolus with the system doing its thing afterwards is absolutely fine for lots of people. If you think, no, that doesn't really work for me, I either dip initially or just stay kind of slightly higher afterwards for a period of time with the system really battling to keep on top of the additional carbs as they come through later, you can split that bolus initially, and so give a certain percentage up front in the bolus calculator. And as a starting point, we just suggest if you did something before using a closed loop system, so if you, I don't know, had pizza or pasta type meal, anything sort of large amount of carbs, and you used to do kind of a 70-30 split, so 70% up front and then 30% later, we'd just say if you think you need to split it, just start with that same split, give that in that example, give the 70% up front in the bolus calculator as you normally would, but then just leave the system to deal with the remainder of the carbohydrate. And again, that it often, for many people, that again will be enough. The system will just deal with the additional carbohydrate as it comes through later on, and it's definitely worth considering splitting the carbs, the bolus, if your carbs are more than about 60 grams. And then going on from there, if you're finding that still not doing what you want it to do, your post-meal glucose is remaining stubbornly above target, then you could try giving your 70% or 80% or whatever you work out you need up front, but then put boost just after you, either straight after you've bolused, or for some people they'll preset it for say an hour after, and then continue it sort of for 4 hours after. It's very individual. It's picking something as a starting point and then using that as your place to say, okay, that didn't quite work, where do I need to tweak from here, making a note of it and adjusting it next time. And then the fourth thing you could do is think about using this new slowly absorbed meal function, which you can find in the add meal section, which we've got a slide on in just a second. So you would do the same. You would give your percentage up front. So say you decided that you're going to have 70% of your bolus up front. Say you're eating 100 grams of carbs. You put your 70 grams of carbs in the bolus calculator as you normally would as a pre-meal bolus, ideally 10 to 15 minutes before. Then what you would do is go to the add meal section in the drop-down menu on the app and add in the additional carbohydrate in that add meal section. And then what that would mean is the algorithm will deliver additional insulin over the next 3 to 4 hours in 6 pulses, still dependent on glucose levels. So if the glucose is low, it won't give the additional insulin, but it will do that to get on top of the additional carbohydrate as it's absorbed later on. So for gastroparesis, this can be utilized as well in that sort of way. So you can see here, you go to the drop down, so you'd give your bolus normally in the bolus calculator. Then for the remaining carbs, you'd go to the 3 little bars top left to the drop down menu. You'd go into there, it brings the drop down menu, go to the add meal section, and then you've got a space to put the amount of carbs. So in that example I used before, you'd put the remaining 30 grams of carbs in there, and then you would tick that it's slowly absorbed meal. And just as a reminder, that's also the section that you use if you are telling the system that you've had to have some hypo treatment as well. In that case, you would tick the hypo treatment box. And just to also remind you, you can also just use that the amount of carbs without ticking either of the boxes. If you've had some extra carbs, so kind of if you've had a bit of a grazing afternoon, or I don't know, you've been at a buffet, that kind of thing, and you might have put a bolus of say 30 grams in initially, actually you've picked on kind of, you think probably an extra 20-30 grams since, you could put that remaining 20-30 grams in that add meal section, not tick either of the boxes, and the system will give additional insulin based on that amount of carbohydrate gradually over the next couple of hours to deal with that as it comes through. And this, just because the add meal function is quite a new one, just is worth just showing you how it shows in Diasend. So what you see is, if you can see there, the initial bolus of 8 units has gone in just before 2 o'clock there, which is the first, and then you see an additional number of little green triangles that go in as the system delivers the extra insulin for the carbs that you put in the add meal, and you can see it in each of those different slides there. The one on the top right, the bolus has gone in there in the evening, and then again in the evening on the bottom slide, and that's how it shows. If you suddenly wonder, hang on, and on the carbohydrate section of each of the day-by-day menus, it shows as if each of them is going in as kind of a 3 gram amount of carbs. It's not necessarily that it is 3 grams of carbs, but that's just how it shows on the system. And so I'd like to introduce Annika to you. So Annika is a patient who has been under our care in Cambridge for a while, who came actually initially for a pump, referred from a centre that didn't have a pump service. So initially just referred for a pump, but actually because we had this technology available, we looked to see if we could get funding to access this for Annika, because we felt it would be something that was beneficial, and that has proved to be the case. So I'll let Candice play Annika telling you her story, and then she's around at the end if anyone has any questions specifically for her.
Hi, my name is Annika, and I have had type 1 diabetes for most of my life. I was diagnosed in 1980 when I was 2 years old. I think that in some ways makes me quite lucky. I've never known what it is to be without diabetes. So I've grown up with it, but it has always been a bit of a beast. You know, having the visual difficulties because of the diabetes, having gastro difficulties because of diabetes, and I'd just been given an MRI scan for my head because there was some concern that dizzy spells that I was getting could be down to damage from diabetes. You start to think, well, hang on, I'm only coming up for 40. I have a young daughter who needs my care, and I've got a problem that I can't control, and I knew what I needed, I just didn't have the tools to make it happen. I started with the technology a year ago, almost to the day, in fact. A year and 3 days, I think we're at now, and I haven't looked back. It's been challenging to get used to. It's 3 separate pieces of equipment effectively to get to know, but very quickly, I was surprised, very quickly I learnt my way around the app, the CamAPS app. The pump is what I need most help with. My husband does the refill for me, but the Dexcom sensors, I manage that myself independently. I can manage the app myself independently, and it was just such a revelation to me to see in real time what my sugar level was doing, where it was going wrong. And you know, we had to get the process going so gently. Because of the history with my eye problem, we had to be very careful to avoid further damage to the eyes by improving the control too quickly. But even so, you know, tiny baby steps, it fell into line so quickly. It's astounding. I'm running at levels that I could have only dreamed of before, and constantly. I wake up in the morning with a sugar level of around 7 every day, and it still amazes me, because before it was always 18, 19, 20. Regardless of whether or not I'd had a hypo in the night. The alarm systems that the app gives have released me from a great deal of my hypo fear. It means that I'm more willing to take a risk on having lower sugar levels, because I know that the technology will warn me if I'm going too low, and I can fix my hypo with a lot less glucose, because I don't panic. I can have the prescribed amount of glucose and watch in real time as the sugar level starts to recover. So I don't feel that need to eat until I feel better. And I can sleep better at night, and that makes such a big difference to every sense of your well-being, just to sleep well and to feel relaxed. If you imagine looking after a naughty child in a labyrinth in the dark and being expected to control it at all times and know what's going on, you get the occasional hint of what might be happening, but constantly you feel you're failing, and the place is getting trashed. And it's like somebody has come along and flicked on the light. You can see everything. You can see the full picture. You can see what you need to do, where you need to go. And it hasn't made everything perfect. That's, you know, for me, for my eyes, it's too late. But for my gastroparesis, I'm already feeling an improvement, which is something I hadn't expected. But I do feel an improvement in how my digestive system is working. Such a privileged position to be given this technology. It's so valuable to me. And I hate to think of going back. Hi, my name is...
Thanks, Candice. That's and mainly thank you, Annika, for sharing such a compelling experiences. We're moving on now slightly from complications related to diabetes to sort of common scenarios that people with type 1 diabetes might experience, not necessarily related to your diabetes, but can make your diabetes management quite challenging. So quite commonly, people are prescribed steroids. These are often used to treat exacerbations of respiratory diseases, COPD or asthma, or flares of other autoimmune conditions, gastrointestinal conditions, or rheumatological conditions. And what we know is a very well-known side effect of steroids is elevated glucose levels. And these happen both in people with diabetes, but also those without diabetes. And you can see at the bottom here 2 sort of CGM or glucose sensor traces of people receiving the most common culprit is prednisolone, which people often receive once a day in the morning. And you can see the glucose levels spiking, and then they come down to normal at night time, which can be really challenging to manage. And you can see also people's insulin requirements. So in the graphs on the right, you can see that the glucose increases, but also the insulin requirements dramatically increase. So how can we sort of use the closed loop system to help manage this? So here are our sort of top tips for if you're receiving steroid therapy for another reason. Firstly, it's really important to stay well hydrated with sugar-free fluids. And it's also important to check for ketones at least every 4 to 6 hours if your glucose is over 14 millimoles per litre. So make sure that you've got ketone strips at home or whatever you use to monitor your ketones. It's important to check your glucose more frequently throughout the day, and consider reducing your sensor high alert, because you may well need to action hypoglycaemia earlier if you're using steroids. One of the mainstays of managing steroid therapy with the CamAPS system is really using the boost, and this makes the algorithm sort of more aggressive. It increases the insulin delivery. It's still targeting the same glucose, but it will address excursions in glucose, so hypoglycemia, more aggressively than usual. You may well also need to use manual correction boluses, and it's worth remembering that you can still do that via the bolus wizard within the app. You just need to tap on where the sensor glucose is shown, and then it will allow you to enter a correction with your usual correction factor. It's also worth thinking about raising your glucose target overnight, and that's because the effect of the steroids tends to, if you're taking them first thing in the morning, particularly once daily prednisolone, the effect of that on your glucose levels will reduce by sort of late evening time quite often. So you want to avoid having hypoglycemia overnight, or even after you've stopped your steroids. So for instance, if you're taking a 5 or 7 day course, perhaps think about raising your glucose target for the following sort of 24 hours until the effect of the steroids is out of your system.
We'd just like to introduce Fiona to you. Fiona has been on the CamAPS system and is currently dealing with breast cancer, which also has the chemotherapy, but also some steroid use. So it's just great to hear her story about how she's dealing with all those complexities at the moment.
Hello, my name's Fiona, and I've had type 1 diabetes for about 33 years now. I have had an insulin pump for about 15 years, and I've got a 13-year-old daughter who, the reason I got the pump was because I was going to have her. And I was diagnosed with breast cancer about 3 months ago. And I have been contemplating looping before, like since the beginning of this year. My pump was up for renewal, so I thought, oh, I'll get a pump that I can loop with. So I just started to look, and strangely, I joined one of the CamAPS webinars the night before I went to the breast clinic for the first time, and thought, wow, that's amazing. So I was sort of in my head I'm playing around with, CamAPS and sort of self-funding that. I was already being a while looping. So I went to the breast clinic, and it was a one-stop shop. So I had a mammogram, an ultrasound, a biopsy, saw the consultant, who pretty much there and then said, it looks very like you've got breast cancer. And I always remember the nurse in the room sort of coming up to me and going, I know what you're thinking. You're thinking, am I going to die? Am I going to live to see my daughter grow up? And that isn't what I was thinking. The two things I was thinking was, I spent this morning talking about how much work I've got to do over the next few months. How can I possibly not be at work? This is awful timing. And then it was like, okay, and what about diabetes? So it was the, how asking questions about, well, how's chemo going to affect diabetes? And at that point, they're like, whoa, just hold on, you might not have to chemo yet. And then I went into another room with the nurse again, and I said, well, this diagnosis has just made up my mind. I'm going to self-fund the CamAPS because I need something to take the brain power away from me. So the CamAPS will do the thinking for me, so I can concentrate on everything else. So that's sort of where I am really. So I've had two cycles of chemotherapy. So this is my brown wig. I have a blonde wig and I have lots of different hats at the moment. But from a diabetes perspective, I think I was probably more nervous about having to take the steroids than I was about the actual chemotherapy, because I remember having to have steroids when I was pregnant and hearing horror stories around steroids and diabetes and type 1, and just thinking, wow, this is going to be an absolute nightmare. So sort of doing sort of lots of reading and thinking, sort of like, and checking out what I need to do. And it was only when I went for my chemo assessment that they said, they just very matter of factly went, oh yeah, well we give you sort of 8 milligrams of IV dexamethasone just 20 minutes before we give you the chemo, and then you take some more dexamethasone for the next 2 days at home. And I think the colour probably drained from my face at that point, in that sort of panic of like, how am I going to deal with that? But actually when it came to, and I had a chat with Sarah before I started my chemo, and she helped me to sort of think about how the CamAPS would handle the chemo. And it was great because I'd only been using the CamAPS for 2 weeks. So my new pump was funding went through in 2 weeks. So I'm submitting the paperwork to having my pump training, which I think is the fastest on record. I think this is my 5th pump or something over the years, and I've never had one that quickly, even though I've been in the past. I've just been replacing my one pump with an updated version. So this is a whole new one in training, which took a little bit of time to get my head around, but then had 2 weeks on CamAPS before I started chemo. And I must say that first week of using CamAPS and the chemo, it was an absolute dream. So I changed my personal glucose settings down to 4.5 because I thought that the algorithm would make the algorithm work a bit harder to get it to that point. I had boost on for sort of 48 hours. And yeah, I think I only went above 14 for about 20 minutes in that first week, which I was so impressed with. I said to my consultant, if I can get 50% in single figures in that first week of having the chemo and the steroids, I would be delighted. So the fact that first week, I didn't really worry about what my blood glucose was doing, and it just allowed me to just, well, basically sleep. That first week after chemo, all I do is sleep and eat a little bit, but is basically sleep. And there's no worry about having to mess about with temporary basal rates and correction doses, because I know, especially the correction doses, not doing that was just amazing, because I think it's so easy to overcorrect and sort of and do and sort of then it all go horribly wrong. So it was really good. And then the second cycle was probably even better. And I think I was 75% time in range for that week after chemo, with me doing very little. So I did exactly the same things as I did in the first cycle. And occasionally I might have given myself a little, an odd unit here and there if I'm thinking, oh, it looks like it could do with coming down a little bit. But generally, it just did it all for me, which allowed me to think about other things and not to have to worry about diabetes. It was like a diabetes holiday, which was exactly what I need, so I don't have to worry about it all the time. So yeah, that's what's going on in my life at the moment.
Thanks very much for that, Fiona, and again sharing your experiences. And I think we're all in danger of losing our jobs with your expertise in managing steroids. We might be coming to you for advice next time. So it seems topical after talking about steroids, thinking about illness and sick day rules for when people are using a closed loop system. So these are specific for adults and not relevant to children, where the ketone threshold is slightly different, but seeing as most people we're expecting here are adults, what we suggest is that if you're unwell and your ketones are greater than 1.5, these are blood ketones, then we do recommend that you stop using auto mode. So you come out of auto mode and just follow your usual pump sick day rules, and obviously contact your diabetes team as required. If you're unwell and your ketones are less than 1.5, you can usually remain in auto mode and use boost plus or minus sort of manual corrective insulin doses as you need. And often we find that the boost can correct things anyway, because it will increase the insulin delivery. Again, it's really important to maintain your hydration, drinking plenty of sugar-free liquids, and keep trying to eat regularly, despite the fact that that's going to have implications on the glucose levels. It's really important to maintain your oral intake. And as with any of these things during illness, it's really important to monitor your glucose and ketones frequently during the illness. But in general, we find that the closed loop system can handle illness better than normal, but it's just in case the ketones are high, it's worth just making sure that you default back to your usual pump sick day rules. We didn't want to focus too much on COVID-19. It's a bit overwhelming at the moment in terms of being everywhere, but it is worth just touching base about what we know about it in terms of type 1 and how closed loop could be used to help manage COVID-19 infection. So we do know that it's been associated with hypoglycaemia and significant insulin resistance. And that's again in people both with and without diabetes, but obviously has more important implications in people with type 1. So again, same rules as we see with general illness: staying well hydrated, monitoring ketones, and keeping an eye on the glucose throughout the course of the day. Consider again reducing the high alert. We know that people might be a bit more prone to ketosis, especially if they're more insulin resistant. So again, thinking about if your high alert is normally up at sort of 18, 20, maybe bringing that down to about 14 when you might want to be sort of actioning or checking ketones just as a prompt. Again, boost is really, really helpful just to increase that insulin delivery. And if needed, as Fiona mentioned, you can always use manual corrections just to sort of get things back into range if boost is taking a little bit too long. So the next section is about looking at a little bit about a study that we've been doing in older adults with type 1 diabetes. And I'll just briefly touch on our experiences with this. So we know from a study which was published about a year ago now that older adults have quite a high burden of hypoglycemia, and this was a nicely named study called the Wisdom Study. And what it did is it looked at with masked sensors how much time people spent in hypoglycemia, and what they showed was that particularly overnight, older adults tended to spend about 5% of time over the course of the 24 hours or 72 minutes a day in hypoglycemia. And often these were people who weren't using glucose sensors, so didn't have any idea that they were hypo. And you can see in the graphs on the right that actually the most of this was overnight. And so during our study, next slide, Candice, thank you. This is called the DAN06 study, and this is a clinical trial where we're using the CamAPS FX system in adults age 60 and over, and actually our oldest participant was 80 during the study. And our experience really reflected this, that we had people that were coming into the study who'd never used glucose sensors before, and actually we were picking out quite a lot of hypoglycemia that people didn't notice that they'd been having beforehand. Some of the considerations we sort of alluded to earlier, thinking about people with visual impairment and some of the difficulties with the pump display, but it was nothing that we weren't able to sort of get round with sort of support and assistance with that. And we also had a couple of people who were using Bluetooth hearing aids that we hadn't sort of thought about beforehand. And we were slightly concerned that these might interfere because all the devices communicate via Bluetooth, but actually this was completely fine and we didn't run into any issues with it. So just a heads up for any Bluetooth hearing aid wearers. And what we've really found is it's been a really rewarding study to be part of, and that actually closed loop systems have had really important benefits for people in the study. We're also looking at whether people's cognition is going to be affected and their sleep quality as well. And on this side, you can just see a few of the sort of quotes of what people have sort of told us about the impact that the closed loop systems had on their quality of life. And really, we want to be reflecting that actually it's not just about closed loop systems for children and young people, that actually older adults have significant benefits from this technology as well. So finally, we just wanted to touch a little bit on how to manage with the closed loop system if you're undergoing surgery or other procedures, things like endoscopy or things like that. So if you are having a surgery or a procedure that you know about, it's worth thinking about whether or not the pump and sensor can safely remain in place and whether you can stay in auto mode during the surgery or procedure. So we would always recommend that you discuss the management of your diabetes with your surgical team and anaesthetist if there's going to be an anaesthetist involved before the surgery. So often people have a pre-operative assessment. Consider where the sensor and cannula are inserted, and you want to be careful to avoid the area. So if you're having abdominal surgery, you want to avoid having your sensor or cannula in that area, because that's more likely that those are going to have to be removed for your surgery. Normally people are asked to fast before their procedure or told to be nil by mouth, and that generally can be very safely managed with the closed loop system. If it's minor surgery or a procedure which isn't requiring a general anaesthetic, you can usually remain in auto mode if you're able to manage this safely around the time of the procedure, and provided this is agreed with the surgical team and anaesthetic team in advance. You might think about setting a higher personal glucose target for the sort of 24 hours around the procedure itself, and maybe putting ease off on before the procedure, just to reduce the risk of hypos when you're fasting or when you're not feeling well enough to eat or drink anything around the time of the surgery. If you're having more major surgery or that which requires general anaesthetic, or particularly diathermy, which is a technique used by the surgeons, which involves how they cut the tissue, and most surgeons will be able to tell you whether your procedure is going to involve diathermy or not. So for some surgical procedures, if they're not going to use diathermy, you can remain in auto mode if that's agreed with the surgical and anaesthetic team in advance, and often they're very happy for people to stay on it. I think the main thing is just informing the team beforehand. If diathermy is going to be used, or if the surgical or anaesthetic team aren't in agreement that you can stay in auto mode, then you just need to switch the auto mode off. You may well be allowed to keep your pump in place and the sensor in place. Some teams may want the pump to be completely disconnected and follow the sort of standard hospital insulin administration policies. The main thing is to talk with them in advance and make sure that you've got a plan. You can also involve your diabetes team as well to help support with decision making before the operation. Auto mode can be restarted whenever the surgical team deem it's appropriate, whenever you're sort of feeling fit enough to cope with it. If the sensor remained in place during the surgery when diathermy was used, you must just do a finger prick glucose check to check the accuracy of the sensor before you turn auto mode on, because the diathermy may affect the accuracy of the sensor. So you just want to check that that's all okay. And if there's more than a 3 millimole per litre difference between your finger stick check and the sensor, then you can always calibrate the sensor in the app, and we would recommend doing this. What about scans? So you may have a CT scan or MRI scan booked, and there's a few things that you need to know about how to handle the devices with these scans. So the glucose sensor accuracy can't be guaranteed during or after a CT scan. So what we recommend is that you turn off auto mode before the scan, but you can keep all the devices in place whilst you go for the scan. Then check the sensor accuracy once you've had the CT by again doing a finger prick blood glucose test. And if it's within 3 millimoles per litre of the sensor reading, then you can restart auto mode. Alternatively, if it's not, you just need to calibrate the sensor in the app. MRIs are a bit more cumbersome because you're not allowed any metalwork in place for an MRI. So you need to remove the sensor and transmitter and disconnect the pump prior to the scan. If you use steel cannula, you'll also need to take off your infusion set. Once the scan's finished, you just reconnect the pump and insert a new sensor and restart auto mode. So hopefully over the last sort of 40 minutes or so, we've covered some of the type 1 diabetes related complications and how you can maybe adjust the closed loop system to suit some of these different conditions. We've considered steroid therapy, and Fiona's given us a lovely example of that, and also covered sick day rules and thinking about how to manage general surgery and procedures with the closed loop system. And we're very happy to take any questions that you might have or catch up with what's been happening in the chat.
Thanks, Charlotte. There's been a nice discussion about the difference between time in range and HbA1c or average glucose levels. What's your feeling about which one is more important when we're looking at thinking about the overall management of type 1 diabetes and maybe reducing the risk of complications?
It's a great question. So I think historically all our evidence has been based on HbA1c. So when we say, oh, these HbA1cs have a lower risk of developing complications, it all comes from HbA1c data. But I think what time in range tells us is much more useful. We can see 3 different individuals with the same HbA1c who might have very different time in range and time above and below target range. So I think time in range is much more informative, but we don't yet have the information about what time in range is associated with reduced risk of complications. There's lots of people putting data into different models that can help us suggest that actually a 70% time in range is really the target that we should be aiming for to minimize the risk of developing complications. And that seems to be a pretty accurate way of doing it. So we're sort of translating HbA1c into time in range until we get that data. I think mean glucose has an additional value to time in range as well. So the range for time in range is quite broad, so 4 to 10 millimoles per litre. And so somebody who has an average glucose of 9 compared to somebody with an average glucose of 6 may have slightly different risks. I don't think looking at mean glucose in isolation is enough, but I think the combination of mean glucose, time in range and time below range can pretty much guide you in terms of your diabetes management and targets.
Thanks, Charlotte. There's another question about how many people in the UK are currently using CamAPS and kind of how many of those are adults versus children. Who wants to take that?
I actually don't know the answer to that. I know it's going up quite quickly every day at the moment, but I don't know the actual numbers, but more and more.
Yeah,
we've got quite a number in trials as well at the moment, particularly in children. We've probably got a couple of hundred children, maybe slightly less than that now. Actually, we've just finished a couple of studies. So probably about 100 children around the UK are using closed loop systems, and a few adult studies ongoing as well. But
I had a quick chat to Roman, and he was saying that it's just under 300 in total. There is a split between, as we said, the research and the sort of commercial users. There is slightly heavier slant towards, if we're looking at the commercial side of things, the children tend to find funding easier than adults, and we're trying to address that and work really hard to work with all the levers to try get more equal access across England for closed loop. And I'm sure those of you who follow social media have seen Parthakar's sort of latest announcements about trying to get more sort of experience for closed loops so that a NICE can have a good amount of real life experience and real life data, as well as obviously the research data that us and others have added to the mix to make a technology appraisal and publish that next year. So that's all really positive. Now, there's some discussions about a localized MRI. Charlotte, you were talking about a wider MRI scan. If somebody, for example, here was asking about having sort of localized MRI for say a dental implant, which is far away from maybe where the pump and sensor is, would that be okay, or is there still a risk? What would your advice be?
So the advice is always to remove all metalwork. So for some specific ones where people might have had metallic hip things, and sometimes they will do localized scans, it's something that you'd need to have a discussion with. But for the sake of removing devices and putting them back in, which is obviously a lot easier than removing a hip implant, then usually people would just say take the devices off rather than err on the side of caution. So the standard advice is always remove them before an MRI.
We've even had a couple of patients who have gone into an MRI room while their children have had scans, and it's caused trouble with their pumps. So yeah,
it's sort of not really worth the risk, I think, if you can't trust the devices. So yeah, we'd always recommend taking them off.
I just thought it might be nice, Candice, if I don't know if Annika and Fiona, feel free to turn your cameras on and unmute, but just to kind of have a think. I think there was lots of chat, like you said earlier, about the time in range and sort of versus A1C and things. And I think, Annika, if you don't mind me using you as an example for that, in terms of when we started with, do you mind sharing what your A1C was when you started?
No, absolutely.
I can't remember. You tell me. Was it in the 80s or the 90s? I can't.
It was, I believe it was 80. Hang on.
It was definitely,
I think it was 82, but
it was up there, wasn't it? And actually, what you'd see on Annika's graphs was that a lot of swinging, wasn't it, Annika? But either you were kind of high or low, and then in between on the way up or the way down, but it was very much swinging from one place to another. And I think people get quite worked up, and especially there seems to be sort of quite a lot of competition when you look at some of the online forums around, you know, aiming for like really high times in range and what targets to aim for. And I think actually one of the things that you can often find is sometimes pushing the target up a little bit actually helps you increase the time in range, because it helps stop the swinging. It helps stop the swinging that's caused by the overshooting. So if the system's aiming for quite a low target, it doesn't give you much room for if it kind of is a little bit too aggressive and you end up overshooting, which then often causes a rebound back up high again. And that normally sets off that whole catalyst of, oh gosh, I've gone a bit high, let's either put boost on or give an additional correction, and it can cause that. And I think often just upping that target a little bit can just help smooth everything out. So it's not necessarily at detriment to the time in range on the whole. And I think we saw that, Annika, didn't we? And that we started with, we didn't really know what to do, what would the right thing to do in terms of Annika's eyes and using the system, and we started with 11. We set it at 11, and I spoke to a couple of the consultants in clinic, and they said, you know, well, why don't you just go down half a millimole target kind of every 2 to 3 weeks, depending on how it goes. So it took us quite a few months to get down to sort of a normal target level with Annika, but actually the time in range, once we got down sort of aiming for sort of 8.59, the time in range was actually pretty decent, sort of up in the 70% quite quickly, even though the target was quite high, and it just, the variability was reduced dramatically. And I think that's what made the huge difference. And you can show off, Annika, what's your what I show off on your behalf, what's your A1C now?
54 was my most recent one.
Yeah,
but that dropped quite dramatically in spite of taking it
even with
slowly.
Us, being careful, it came down quite quickly, but that was kind of the best we could do. But dramatic effects. So yeah, I think it's sometimes, if things are just, doesn't matter who you are or sort of what's going on in terms of, you know, not necessarily complications or anything, if you're kind of getting quite a lot of ups and downs and sort of that sort of sawtooth effect, sometimes just push the target up, even just for a few days, just till it all settles down a bit, and then you can nudge it back down gradually, and that can make a huge difference. I'm just looking at the other questions there, Candice. Is there anything?
Yeah, no, I've been looking, so that there's lots of chat, so thank you very much for that. And I don't know, Charlotte, if you saw, there was one comment about somebody's feeling that their hypo warning signs are massively improving now that they're on CamAPS for the last 7 months. So that's great to hear that feedback is kind of widely experienced. I think there was a question about Adneal, but I think it was then covered following that. I'm just having a look. There was a question about CGM and Dexcom. Dexcom's the only CGM that is able to be used with CamAPS at the moment. You were saying the Dexcom G6 will come, and
G7, yeah.
I mean G7, and obviously the app is designed to be interoperable. So as CGM develops and there are new players in the market, there may be opportunities to link with different systems, but the system we've got in place is what we have at the moment. And yes, unfortunately, we are still waiting for Dexcom Share. We have been told by Dexcom, hopefully it'll be Q3, Q4. So in their terms, sort of latter half of the year that we will get that share. So we will be able to have follow as well as clarity. But as soon as we get it, we'll let you know and put it in place. Any last questions before we bring this very interesting webinar to a close?
Go has just asked about the trial sites for the pilot. People have been asked to put in, so they've gone to all the biggest pump centres and asked to provide data, because they're looking particularly for people who are on pumps and Libra, because that's how the funding will work. They only really want to fund the difference between Libra and pumps, and you could potentially argue that actually if someone's on a pump but not getting the sort of optimal control that we'd like to see, that the first step would be to put them on Libra with their pump, and then closed loop or CGM with closed loop would be the next step in the pathway potentially. So they've kind of gone to the biggest pump centres that you can see on the national diabetes audit, and then it's up to those centres to provide their data to see if they have got enough patients to take part.
So 20 adults and 5 pediatric centres, I heard.
Yeah.
And hopefully that will be starting shortly. So we'll let you know as soon as we do. Any other questions not covered? I don't see any there. Anybody else spot anything or wanted to say anything? And I just want to thank Annika and Fiona again for contributing and sharing their stories. It's really, really appreciative. We have uploaded their stories onto YouTube. So if you want to listen to a fuller story, Annika's shared a little bit more as well, so you can watch that. Fiona has kindly offered to work with us and look at sort of writing a blog of how her experience has been over the time. So do watch out for that on social media, and you know, we wish you both well. So thank you very much for contributing.
Thank you for having me.
No, it's brilliant. And Fiona, do you want to say anything?
So yesterday I had my 3rd chemo session, and about sort of 6 o'clock last night, my sensor stopped working, and I had to go back to sort of using sort of manual corrections for a few hours. It really freaked me out. So I was glad to see when it came back on. Different life would have been if I hadn't got CamAPS compared to doing it the traditional way. Yeah.
Thank you. Thank you very much for sharing, and thank you very much for everyone joining us tonight. I hope you have a wonderful rest of your evening, and keep safe, and see you next time. Thank you very much. Bye.